Thank you, Mr. Saga, for the introduction. And I'm Dr. Ndagurwa, and will be presenting on the protocol for the multiple pregnancy for women with multiple pregnancy. Before I go any further, I just want to remind everyone that twins are at an increased risk of fetal and infant death as compared to singleton births. And this is mainly due to the lower birth weight and also the lower gestational age at delivery. And if we are to compare the outcomes of the monochorionic and dichorionic twins, find that the monochorionic twins have poorer outcomes as compared to the dichorionic twins because of other complications that we see affecting the monochorionic twins specifically. Sorry about that. Okay, so I was saying if we compare the outcomes of monochorionic twins versus the dichorionic twins, we'll find that the monochorionic twins have poorer outcomes due to other complications that specifically affect monochorionic twins, and some of the complications are the fetal transfusion syndromes, like twin-to-twin transfusion syndrome. In most of the African countries, women with multiple pregnancies receive insufficient care, mainly due to lack of knowledge and also due to lack of resources. And in these countries, you find that there are no guidelines that address the special care that the multiple pregnancy mothers need. And also, there's no specific training for scanning of women with multiple pregnancies. So it is against this background that we decided to establish clinics that are dedicated to scanning women with multiple pregnancies. And here in Zimbabwe, we are currently running at least 3 clinics per week. And these clinics are being run by fetal medicine midwives, specialist obstetricians, and our fetal medicine specialists. In these clinics, we are seeing all the types of twins, triplets, quadruplets, and higher order pregnancies. And these are mainly referrals from the public and the private sectors. Also, before I proceed, I want to emphasize that there are important factors that we should bear in mind when managing twins. We should always remember that we need to accurately determine the gestational age and chronicity of each pregnancy because these have significant prognostic value. The chronicity is the most important determining factor for the surveillance, the complications that we are going to anticipate, and also the fetal outcomes as well. In our units, we start following up women with multiple pregnancies from the first trimester. That is, we start scanning them from 11 weeks to about 13 weeks plus 6 days, where we perform the first trimester scan. And Dr. Verenga has already explained all the things that we do in the first trimester scan. I'll just re-emphasize that at the first trimester scan, we need to confirm the type of gestation that we are dealing with. Is it a twin pregnancy? Is it a triplet pregnancy? Is it a quadruplet pregnancy? Is it a singleton? We also need to confirm viability of all the babies that are inside the uterus. And we also need to confirm the location of all the fetuses that are inside that we are seeing. At the same time, we assign chronicity, and for this we use different methods. We can count the number of placental masses that are visible. This we are able to do if the placental masses are distinct and clearly visible. If there's one placental mass, we have to assess the intertwin membrane, and we assess the thickness of the intertwin membrane. If it's looking thin and looking like a T, we say it's a monochorionic pregnancy. If the intertwin membrane is looking thick, then it's a dichorionic pregnancy. Then we have to label the fetuses so that we can follow them up as such. So for labeling, we mainly use the fetal position. In our unit, we are saying the fetus that is on the maternal right side is twin 1, the fetus who is on the maternal left side is twin 2. And also, we can say the fetus who is lying closest to the maternal cervix becomes twin 1, and the fetuses who are in other positions are labeled as such. If we are able to see the gender and we are having a female and a male, then we can also use the gender. That is if the labeling using the fetal position is difficult. We can also use the location of the placenta and also the level of the cord insertion. This is mainly in monochorionic pregnancies, and we only do this if labeling using the fetal position is very difficult. We screen for aneuploidies, and Dr. Berenka has already mentioned the trisomy 13, 18, 21, and also Taylor syndrome and how exactly we do that. And we also screen for major fetal anomalies, including holoprosencephaly. At the same time, we screen for preeclampsia using uterine artery Doppler studies. And we also take advantage of the small uterus to assess the maternal adnexia to exclude adnexal masses like fibroid or I have already explained that if for determination of chorionicity, if we have two distinct placental masses, then we are able to assess our chorionicity using the placental masses. Some of the cases, the placenta, we just have one placental mass, and we have to assess the intertwin, the thickness of the intertwin membrane. And if it's looking nice and thin, like what is shown in image A here, then it's a monochorionic pregnancy. And if it's looking thick, it's a dichorionic pregnancy. In our units, we are seeing all sorts of multiple pregnancies, and these include twins, the monochorionic, dichorionic twins. We have also seen triplets, and there are different types. We have also managed quadruplets. I'll start off with the monochorionic twins. These ones, we start following them up from 16 weeks. So from the 12-week scan, we go on to see them at 16 weeks, where we start the screening, like active screening, for the common complications that we know that they affect monochorionic pregnancies. So at every visit, we are actively looking for twin-to-twin transfusion syndrome. We are looking for TEPS. We are looking for fetal growth, selective fetal growth restriction, single intrauterine fetal demise. We are also screening for preterm labor and other rare conditions like TREP. So we do this by assessing the fetal growth. We assess the Doppler studies, umbilical artery, mid-cerebral artery, and ductus venosus. We also assess the amniotic fluid volume using the single deepest pool in each sac. We assess the fetal bladder volumes, and we compare the volumes of the bladders for both twins. We assess the cervical length using transvaginal scan. And then at 18 to 22 weeks, we perform a detailed anomaly scan looking for the abnormalities that Ms. Chigago was explaining earlier. If the pregnancy is complicated by twin-to-twin transfusion syndrome, we also perform fetal echocardiography. For the timing of delivery for the monochorionic, the advised delivery between 36 and 37 weeks, and This is for the monochorionic diamniotic, and if it's a monochorionic monoamniotic, we advise delivery between 32 and 34 weeks. Okay, so at every visit, we are assessing the estimated fetal weight of each fetus by way of assessing the biometry of the head, the abdomen, and the femur length. And then we calculate the fetal weight discordancy. And if it's more than 25%, then it's significant. Then we look for other things like the amniotic fluid volume. If that is associated with a discrepancy in the amniotic fluid volume of more than 6 centimeters, or if there is membrane folding on one of the twins, then that becomes diagnostic of twin-to-twin transfusion syndrome. If you are just having an estimated fetal weight discordance of more than 25% without any discrepancies in the amniotic fluid volumes or the fetal bladder volumes, that becomes diagnostic of selective fetal growth restriction. As you can see in this image, if it's a monochorionic pregnancy, we do scan the babies at the same time, and we flight the images on the same plane so that we can actually see that one of the tummies is looking bigger and the other one is looking small. So we do this for the head, the tummy, the femur length, and the other things so that we can pick things in real time. We also compare the amniotic fluid sex real time. We flight them on the same image. We can see that in this image, we are having lots of liquor, and then on this side, and then there is little or almost no liquor on the other side. And after that, we perform fetal Doppler assessment, the umbilical artery, midcerebral artery, ductus spinosas, and we particularly look for discordancy in the midcerebral artery peak systolic velocity, where we'll be looking for steps. For twin-to-twin transfusion syndrome, we actively screen for this condition from 16 weeks. And this is because we'll be looking for early twin-to-twin transfusion syndrome, which can actually start before 16 weeks. We know that twin-to-twin transfusion syndrome arises when there is a connection between a vein and an artery from the vasculature of either twin 1 or twin 2, and we end up having differences in pressure gradients, and there's transfusion of blood from one twin who becomes the donor to another one who becomes the recipient, and we end up having fluid, circulatory fluid discrepancies, which then result in all sorts of complications that we see in the donor and the recipient twin. We stage the condition using the Quintero staging system, and so far in our unit, we just use conservative management and serial amnio reduction for stage 1 at less than 26 weeks and stage 2 at more than 26 weeks. If we continue to have severe polyhydramnios or other complications after 32 weeks, then we advise delivery. In other settings, they do have laser ablation, septostomy, and cord coagulation, but in the meantime, we don't have such in our unit. Then I'll move on to selective fetal growth restriction, also affecting monochorionic pregnancies. I have already explained that we diagnose this condition when we have a discrepancy of more than 25% in the estimated fetal weight. We can also pick it when one of the babies is not growing well and is growing below the 10th centile for its gestational age. And if there is abnormal umbilical artery Doppler studies in one of the twins. This condition mainly arises from unequal sharing of the placenta. As you can see in this image, we have one of the twins, the umbilical cord has inserted almost at the center of the placental mass. Its vasculature is well established. It is spanning throughout the whole placental mass. We have another twin whose cord is inserted at a little corner, and the vasculature is not so healthy and is obviously not getting enough nutrients and oxygen. And this baby is going to grow to achieve its genetically determined fetal weight, and will end up having selective fetal growth restriction affecting this baby. So for this condition, if we pick this condition, we scan that pregnancy every 2 weeks, of course, checking the estimated fetal weight and the Doppler studies as well. And then we deliver according to the gestational age and Doppler studies of the smaller twin. We can also have single intrauterine fetal demise in monochorionic pregnancies, and though this is a bit rare for monochorionic pregnancies, if one of the babies die, most likely the other one will die in a few hours or in a few. But in the few instances when there's a survivor, we scan them every week, assessing the Doppler studies until they stabilize, and then we start to see them every 2 weeks, assessing the growth and the Doppler studies as well. And then we advise delivery according to the gestational age or the Doppler studies of the surviving fetus. We do have other fetal transfusion disorders like TEPS and TREP sequence that can also affect monochorionic pregnancies. For TEPS, which is twin anemia polycythemia sequence, we have small, very small caliber connections that are deep within the placental mass, and these result in slow but chronic transfusion of blood from one twin who is the donor and the other twin who becomes the recipient. Because of that, we end up having a discrepancy in the hemoglobin levels, and one twin becomes anemic and the other one becomes polycythemic. In this condition, we don't have any amniotic fluid volume discrepancies, and this is how we differentiate this condition from twin-to-twin transfusion syndrome. We mainly pick this condition by way of using the middle cerebral artery systolic velocity where we find that the peak systolic velocity for the donor twin has a high velocity because of anemia, and also the peak systolic velocity for the recipient twin has a low velocity due to polycythemia. We stage this condition using the Leiden staging system, and in our unit so far, we are just using conservative management because we don't have fetoscopic laser or fetal blood transfusion available. Okay, so I'll move on to the TREP sequence, which is a condition that arises when one of the twins is transfusing blood to both twins because
we seem to have lost sound for you, Dr. Ndagurwa, and you also have 1 minute left.
Okay, Ms. Zanga, can you hear me now?
Yes, we can hear you now.
Okay, so for the TREP sequence, which is a rare condition where we have one of the twins supplying blood for both twins, and this twin is actually developing normally, and we have an acardiac twin who does not have a heart and is not fully formed, does not have a proper body, and missing the head, the limbs, and the torso. So in this case, we just monitor and do conservative management for the sake of the twin who is developing well, and we assess fetal growth and Doppler studies every 2 weeks, and then we deliver according to the gestational age and the Doppler studies of the normal twin. In other centers, they do have radiofrequency ablation, cold occlusion, but for us, that is not available at the moment. Okay, so for the dichorionic twins, again, we start following them up in the first trimester, and after that, we see them again for the second trimester scan at 18 to 22 weeks. We see them every 4 weeks, assessing the fetal weight, the Doppler studies, and the cervical length, and we'll be trying to actively screen for the common complications that affect dichorionic twins, and these include selective fetal growth restriction as the most common complication, single intrauterine fetal demise due to various causes, discordance for fetal abnormalities, pre-labor, and preeclampsia. We advise delivery between 37 and 38 weeks. For selective fetal growth restriction, if we pick this condition, we see these patients every 2 weeks, where we assess the fetal growth and Doppler studies, and we advise delivery according to the gestational age of the pregnancy or the Doppler studies of the smaller twin. If one of the babies has died, we see these women every week until stabilization, and then we see them every 2 weeks, assessing the growth of the survivor and the Doppler studies as well. And then we deliver according to the gestational age of the pregnancy or the Doppler studies of the surviving twin. For the mode of delivery, at the moment in our unit, we advise that twins be delivered by cesarean section. Sorry about that. Because at the moment, we don't have continuous electronic fetal heart rate monitoring for both twins. However, if the woman presents in labor or if she wishes to deliver vaginally, we allow for vaginal delivery if both babies are in cephalic presentation or if one of the babies is in cephalic presentation. But if it's a breech or transverse lie, we advise cesarean section. For the triplets, we have managed triplets in higher order. We have managed a few sets so far. And again, we start seeing them at the first trimester scan. And thereafter, we see them every 2 weeks, assessing the fetal weight, Doppler studies, and the cervical length. For this, we'll be trying to actively look for the complications that affect these pregnancies. And these complications are just similar to those that affect monochorionic pregnancies. Sorry about that. So our twin transfusion syndrome, TEPS, and also selective fetal growth restriction, that's what we will be looking for. After the first trimester scan, we perform a detailed second trimester scan looking for complications which are also more common in these higher order gestations. For triplets, we advise delivery between 32 and 34 weeks, and quadruplets, quadruplets and higher order, we advise delivery between 30 and 32 weeks. That will be my last slide. Thank you for listening.